If I need a central line and need it now, there's one place I'm going. Subclavian. Now, the first time I did this, I was freaking out. What if I cause a pneumothorax? It seemed really scary. But it's actually just as safe or safer than the jugular vein. And in this video, I'm going to share with you my tips, tricks, and troubleshooting steps I've learned over the years to make you a subclavian line champion. Landmark-based subclavian central line placement is a core skill in acute care medicine. A favorite go-to approach of many anesthesiologists, surgeons, ICU, and ER docs, it's a relatively easy technique but requires an understanding of the anatomy and some technical aspects. Now, some of you might be saying, hold up, I like my internal jugular site for central venous access. Why can't I just stick with that? Well, the IJ is nice, but sometimes you can't always rely on that approach because there's a mass or infection at the site, or it's clotted or kinked. C-collars also tend to interfere with necklines. Also, the subclavian approach is associated with fewer infections than the IJ or femoral approach. But the main reason I love subclavian is that it has a consistent relationship to the underside of the clavicle, an easy, bony landmark. This makes the subclavian approach fast and reliable. Bones don't lie. There's also the advantage that the vein is held open by fibrous attachments to the fascia between the clavicle and chest wall, which means it doesn't collapse in shock or hypovolemia and doesn't change diameter with respiration or head-down positioning. It's therefore the ideal trauma line. Finally, subclavian lines are more comfortable than IJs. Nobody likes having a plastic apparatus taped to their neck. Here's the anatomy. The axillary vein becomes a subclavian vein at the first rib and then arches over and down behind the sternum as the brachiocephalic vein. There's a very consistent relationship between the subclavian vein and the S-shaped clavicle. We're going to palpate the medial angle of the S here, where the clavicle turns superiorly. Our needle is going to enter the skin 2 to 3 centimeters lateral to that point and aim for our finger, which is on the sternal notch. By slipping just deep to the clavicle along that trajectory, we can't help but puncture the subclavian vein, which lies just deep to the bone. Now, some people get scared of the risk of pneumothorax, but the rate is actually quite low, and if you're careful to aim properly, you'll have no problems. What you don't want to do is aim deep. That will take you, naturally, into the chest. Instead, you want to have a trajectory that is parallel to the floor and travels just deep to the clavicle. I tell the trainees to scrape the paint off the underside of the clavicle. I don't mean get lodged in the periosteum, but the point is to stay shallow enough to hug the underside of the bone. As mentioned, the head-down position won't help all that much to make the vessel an easier target like it does for jugular cannulation, but head-down will help reduce the likelihood of an air embolus. In addition, 2 maneuvers will help make life easier. First, you want the shoulder slightly lower than the chest. If practical, we'll often put a rolled-up towel or a 1-liter bag of saline between the shoulder blades. Second, with the arm adducted by the patient's side, apply slight caudal retraction of the arm. An assistant can help with this if the shoulder is tending to slide toward the head. These 2 maneuvers ensure the maximum amount of contact between the vein and the underside of the clavicle, improving first-pass puncture rates. With the patient's chest prepped and draped, you'll want to do the following steps before skin puncture to make things go as smooth as possible. First, attach your needle and syringe. Next, make sure the wire can move freely and the tip is retracted to within the hub. Then make sure your dilator is handy, as well as your scalpel or blade. And finally, if you have time, flush the non-wire catheter lumens with saline. If you're under the gun for time, this is not a critical step, as long as you're aware there's air in the lumens that will need to be aspirated before flushing. Okay, we're all set. Here's my 4-step technique for getting into the subclavian vein. Step 1, palpation. Take your non-dominant hand and rest your middle finger in the sternal notch. This is what you're going to be aiming for. Hold your needle and syringe with your dominant hand. I like to think of this as playing pool. You're going to line up your hands and needle like a billiards player would with a stick. You'll then feel the contour of the clavicle with your thumb and determine where the S curve is. Keep your thumb at the medial end of the S, where the clavicle starts to turn north. Step 2. Line up your middle finger and thumb. On that same line, puncture the skin 2 to 3 centimeters back, flatten your needle angle, and advance so you deliberately contact the clavicle. Step 3. Retract slightly and scoop under the clavicle while aiming for your finger in the notch. Now, it's important to understand the movement here. You don't want to aim deep. You want to keep the needle roughly parallel to the floor. Your thumb can be used to feel the shaft of the needle under the skin and to push the whole thing deep enough to slide under the clavicle. That way, you're staying shallow and away from the chest wall. Step 4. Advance towards your finger. Maintaining that angle and trajectory, push the needle towards the sternal notch while aspirating on the syringe plunger. At some point, you're going to get a sudden rush of venous blood into the barrel. Stabilize the needle with your non-dominant hand and then remove the syringe. You're checking to make sure it's a slow trickle of venous blood and not the bright red pulsatile kind. Dark trickle good, bright jet bad. Now you can advance the wire into the needle, feeling for resistance. It should pass smoothly. There is rarely a need to insert beyond about 20 centimeters or so. After withdrawing the needle, load the dilator onto the wire. Then take your blade and make a controlled stab incision at the entry site with the sharp side up. Now don't be shy. Incisions that are too small are a common cause of dilator or catheter hangup. I use my other hand or thumb to provide counter traction on the skin so the wire doesn't buckle and kink as I advance the dilator. You don't need to go the entire length, only about as far as you think the vein is, usually about 3 to 5 centimeters. The puncture site is likely to bleed a bit when you pull out the dilator. I use my finger or side of my hand to place some pressure on the site while I'm loading up the catheter. Retract the wire until several centimeters are sticking out the lumen of the catheter. This will allow you to control the wire and not lose it in the patient. We still hear of this happening. Don't be that person. Using the same counter traction on the skin, advance the catheter. It should also go relatively easily now that you've dilated the tissues. Now you can remove the wire and flush the ports. Make sure to aspirate the air out before injecting saline. Then all that's left is to sew it in, clean things up, and apply a dressing. Oh, and high-five your colleagues. Now, of course, things don't always go perfectly smoothly, so here are some general principles as well as some troubleshooting tips and tricks. When should you not choose the subclavian site? There are a few reasons to go somewhere else. If there's an infection or existing device at the placement site, if the vein is known to be thrombosed, or if there are fractures at the ipsilateral clavicle or the first or second ribs. Coagulopathy is a consideration, not a contraindication. Remember, there are fewer arterial punctures with a subclavian route compared with IJ. But if you do hit an artery with a large needle in an anticoagulated patient, it is more difficult to compress. So, like everything else in medicine, you have to weigh the risks against the benefits and consider if subclavian is still the best choice. What happens if you've advanced the needle in fairly deep and haven't had flashback? First off, it may not be because you've missed. It's not uncommon for the walls of the vein to compress with the advancing needle. Try withdrawing slowly while maintaining constant negative pressure, and as the needle falls back into the lumen, you'll get blood return. If that doesn't fix things, the most common error is that you've aimed too inferiorly. Recheck your landmarks and aim slightly more cephalad. If you get an arterial puncture, this happens because you've aimed too superiorly. Arterial needle puncture is one of the most common complications of central line placement, but it's typically not a big deal if you recognize it prior to vessel dilation. If this happens, take the needle out and apply pressure for 3 to 5 minutes. If you encounter resistance to guide wire advancement, try the following. First, rotate the needle and/or the guide wire to rotate the J-tip and possibly relieve contact with the posterior vessel wall. The second thing to try is to pull down gently on the shoulder. The left side tends to be easier and associated with a lower rate of catheter malposition than the right, if you have a choice, and this has to do with the angles of the veins as they go towards the SVC. There are two kinds of people in this world, those who use steel needles for central lines and those who use angiocaths. For jugular veins, the angiocath is nice because you slide off the cannula and don't have to awkwardly hold a sharp needle immobile within the vein while advancing the wire. The downside is they're shorter than the steel needles, and for subclavian lines, the vein can be quite deep. I've watched residents thread off the cannula only to have it land outside the subclavian vein. Oops! Steel needles are also thicker and resist bending when negotiating the underside of the clavicle. For those reasons, I'm in the steel needle club, but in the end, whatever you're used to is often the safest. The subclavian approach is tried and true and an excellent first choice in many situations. It can be intimidating to the novice, but once you understand the geometry and steps to stay safe, there's a good chance that, like me, it'll become your favorite central venous access approach.